Good morning. Today is November 9th, 2021. My name is Crystal Bauer, and we are conducting an oral history interview with Dr. Harmsen on her experience as a family doctor during COVID-19. Dr. Harmsen, could you please confirm for the record that you are aware that this is being recorded and that you are giving your permission to do the interview?
Yes, I'm aware.
Ah, great. Would you please give us your name in full?
Jody Harmsen,
And what is your present title?
physician. I'm
Physician?
an independent physician.
Okay. And where are you located?
I am in Iowa City, Iowa, is where I live, but I don't work here.
Oh, can I ask where you work then?
Yes, I travel. So Iowa City is an urban center in Iowa, small, but it's an urban center in Iowa, and I work rural.
Okay. The surrounding areas then, state or?
Pretty much, yeah. I mean, I work in Northeast Iowa, and I do have a couple of areas in Central Iowa and Western Iowa. So not always just surrounding. Actually, I travel quite a bit.
Oh, good. Uh, Thinking back, where did you go to medical school?
I went to medical school at the University of Chicago on the south side of the city.
Okay. And where did you attend residency?
I came back to Iowa. I went to residency at Mercy Family Medicine residency in Mason City, Iowa.
And then decided to stay there once you were done with residency?
I grew up in Iowa.
Okay.
My family are all dairy farmers, and so I grew up rural, and I knew I wanted to come back and do that kind of work.
That's great. All right. Well, could you kind of describe your employment right now as a family doctor, what you do on a daily basis?
Sure. So I actually went independent in 2018. There were a lot of things that changed right around 2016 for me. And so right now, I actually am self-employed and I cover in small critical access hospitals. I do both hospitalist medicine and ER medicine. Periodically, I'll cover in some clinics as well, some outpatient.
So I'm assuming since you're independent and you kind of work with different hospitals, do you kind of see a different type of patients, or are they all fairly, what does your population look like that you treat? Is it pretty diverse or?
So actually, so I see majority rural, and Iowa is majority white state.
Okay.
93% of people who live in Iowa are white. So I see generally like I would say the majority of people I see are rural white members of our community. But I do see a sprinkling. Because I work mostly in the ER and the hospital, I see all walks of life, but not as diverse as you would see in an urban center.
Sure. So thinking back to the onset of COVID-19 in 2020, could you kind of describe how it first impacted your area and your practice as a doctor?
Yeah. So interestingly, Iowa got hit later, right? Iowa's a rural state, only a couple of large urban centers, and so we got hit a lot later, and people were pretty complacent. And then when we got hit hard because of the complacency and unfortunately, some of the political beliefs. Um, and we have our government initially, Iowa's state government initially um, did some pretty good things and uh, we encouraged masking and schools doing hybrid kinds of things, and so trying to prevent some of the spread. But where I work in the rural areas, um, there was a lot of complacency and attitude that it's not going to come here. It's a big city problem. Um, Unfortunately, of course, because people travel, it did come there, and then those communities got hit really hard. And so actually, I ended up working more while some of my clinic colleagues were laid off. um, or we're working from home, we're doing all telemedicine. And some clinics actually lost a lot of providers, and as did hospitals, because when the pandemic first started, um, the hospitals weren't doing as many of the elective procedures. And so, a lot of the small hospitals, the critical access hospitals, they really rely on those procedures to stay afloat, because the majority of the patients are Medicare, Medicaid, and reimbursement is not quite as good. And so it's hard to stay afloat. And so they rely on their cataract procedures and their colonoscopies, and some of the specialists coming in and doing those procedures, and those all shut down. And so a lot of the hospitals also let go of a lot of staff. And so working the way I do, my hours picked up. So I did a lot more working. I covered a lot more in the hospitals and in the emergency departments. And then when COVID would hit those small communities, it would hit them hard. And in a lot of the rural areas, it's very geriatric. There's a lot of, especially in Iowa, there's been a lot of youth flight to the urban areas. And so, for instance, the county where I grew up in, Clayton County, in Iowa, my whole family was there. The majority of them are still there. So my mother graduated from high school there. My father graduated from high school there. They're all, and they graduated with classes of 100 people, right, in their little small communities. I graduated with a class of 48, and my nephew, who still lives there and graduated, his class was 32. So it's just, there's been a lot of young flight, and so older people are there. So you have a lot of nursing homes and a lot of assisted living and senior apartments, and COVID just wiped out many, many, many people. And the hospitals were full, and we had no transfer centers. And I just remember working in a small town in Clayton County, where it got hit. The two nursing homes got hit really hard, and the floor was full of COVID, and we didn't have any transfer centers. They were full, and so we had a lot of death. And because we couldn't keep intubated patients for more than like 24 or 48 hours, because we just had the temporary events. So there was a lot of hard decisions being made by families. And then it went through the schools. And, kids usually would get through it, but they would bring it back to their relatives. And so really got hit hard. My own stepmother died. She was in the nursing home, and she died from COVID, from it being brought in by one of the nursing staff, brought it in from home. And you have, before the vaccination, the nursing staff lived at home with their family. And there was, again, a lot of political views that prevented a lot of masking outside of the healthcare field. So people would go out and just behave as if it's a normal, and then bring it back to the people they were caring for. So it was a really stressful time, and it was super hard, because you would go to work and see all of this really kind of awful thing going on. The families couldn't come in because we had all kinds of visitor restrictions.
Sure.
And I mean, myself, when my stepmother was dying, she was in the ICU at one of our referral centers, and we had to FaceTime her in her last hours. I mean, it was very, very difficult. And so that's kind of the experience I had at the beginning, when it all happened. When it was going on in the big cities in New York and whatnot, I was behaving as if it's never going to come here.
Right.
So, but then it did, and it got very difficult. Now, after, if you want to talk about post sort of vaccination and post, when we were having shortages of PPE, same thing happened in the small towns. We had, like, I would have to wear the same N95 shift after shift after shift after shift. And we would save even the regular surgical masks, and you'd put them in a little paper bags. Some of the hospitals would do their little hydrogen peroxide spray and all the little things that you would do to try to reuse and reuse and reuse. The small communities actually did rally around some of the small hospitals, and there were, some of our older ladies would stitch up some masks for people to use. So we'd have masks being dropped off at the hospital, and then there would be some of the community, eating establishments would bring food for the nursing staff, and then there was we had a couple of the small manufacturing in some of the small towns. We had actually created face shields, actually made face shields for the clinicians, and brought in other. There was one textile small little textile company that made gowns for us, reusable. So they did rally initially when it became apparent that we were really getting hit hard. But after sort of supply chains worked again, where we got the stuff that we needed, we didn't have to conserve as much, and more treatments became available, and the vaccine started to become a reality.
Right.
That was all sort of forgotten.
So I had one follow-up question with that. Since you were in kind of a unique perspective of being able to go to different hospitals, do you recall what really worked for some hospitals and what didn't, as far as like changing their policies? I mean, were some hospitals more successful in handling COVID than others that you recall?
Yeah, that's a very good question. So I would say, this is my personal experience, would be it depended on the buy-in by the staff.
Gotcha.
So the critical access hospitals, unfortunately in Iowa, there aren't very many independent critical access hospitals anymore. They couldn't make it on their own. So the majority of them are bought up by some of the big systems, which is not a bad thing necessarily. It's just the state of affairs. And so the majority of the hospitals, critical access hospitals where I work and worked, are under the Mercy One umbrella. I don't know how familiar you are with the Mercy One. It's Trinity Health is sort of the entire umbrella, and then you've got the Mercy One, and then so in Iowa, the three big systems are Mercy One, Unity Point, and the University of Iowa, of course. And so the Mercy One hospitals where I worked had because they were affiliated with a large group, including some urban hospitals, they had great protocols that were always coming down and being updated and implemented. And there was always something for administrators and whatnot to fall back on and say, well, this, I know you might not agree with it, but this is Mercy One policy. Right. So, there would be grumbling. I don't want to have to wear a mask all the time, blah, 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 but by the staff, but they just knew they had to buy in. So the couple of independent hospitals where I work, it wasn't that way. And so it was a different experience. Completely. So I feel like it really depended on buy-in by the staff, what kind of experience I would have as a physician, as well as what kind of experience the patients would have.
That makes sense. Could you describe, and you mentioned this briefly, the vaccine rollout, and how that has impacted your experience as a family doc and kind of the reception to both the staff in your hospitals, as well as, the patient reception to it?
Yeah, so it's
Big question.
very interesting. So personally, one of the hospitals where I work at is my family hospital. My first job outside of babysitting was at that hospital. I worked as a high schooler. I worked in the cafeteria, right? Um, so in that particular hospital, where I know a lot of the patients that are coming in, like they were my teachers, they were, they're my family members of my friends from high school, or they are my friends from high school, unfortunately, or things like that. So in that community, it's a very rural community, and politically speaking, very conservative, but rally around each other and will protect their community at all costs. But unfortunately, in this world that we are living in right now, where there's so much vitriol regarding thoughts about who should be in charge, um, it was very difficult. So the hospital, being under the Mercy One umbrella, was uh, one of the early organizations that required vaccination for everybody that works there. Being under the sort of Catholic umbrella, they do allow some religious exemptions, but in general, you were vaccinated or find a new place to work.
Wow.
Uh, so unfortunately, because of, like I said, the sort of political vitriol that's going on at this moment, there were a lot of people who were upset about having to be vaccinated,
Yeah.
those who actually work there. Um,
Okay.
and so, and a lot of our in the communities, a lot of it was mostly nursing staff and support staff. The physicians generally were like,
Sure.
line me up.
Sign me up.
Now, can I get mine now? Because, that made it very difficult. Sometimes there's some animosity just amongst the staff because of things like that.
Oh,
It was a rough, and in the rural areas, in my experience, you know, literally the majority of staff are women.
yeah.
Female CEOs, female clinicians, female, all this, like majority of support staff. So that makes it difficult. Just working with people who are raised to be kind to everybody and let everybody feel good, but then behind when
Yeah.
nobody's around, that's when you start, being more
Yes.
nitpicky about
Yes.
each other. So that made it difficult. That aside, so I think the hospitals are working through it. So in that, we had some definite issues with people just leaving. Like I'm not doing it,
Yeah.
so
I'm gone.
I
So you have staffing shortages, would you say?
So there would
And
be some staffing difficulties, yeah. And so then and already there's minimal staff at
yeah.
Small Creek Lexus Hospital. So people were working double shifts, and it was difficult for those who were hanging on.
Yeah.
And then those who were there and saw the effects of COVID in a little tiny hospital, when we can't transfer anybody out and you're doing everything that you can, but you don't have the capability to access to certain things, I mean, that takes a toll. And nursing staff in particular, who are constantly with the patients. And so we had a lot of hardcore old school nurses that were like, I'm going to stick with this. We're going to do this. But we were losing some of our younger nurses that have more reserve. So
Yes.
it made it very difficult. That's on the staff side, but on the patient side, um, it was even more difficult because the patients would come in, and I'd always ask their vaccination status um, at the time when vaccinations were finally available to the regular public. And the majority would say no, and I'm not getting that because, I'm going to be microchipped, I'm going to be whatever
Yeah.
they're buying into at the time, or I don't believe in it. COVID's not real. It's a communist plot. I've heard it's a left-wing liberal plot. I mean, I've heard everything. It's the China virus. And these are very common conspiracy theories in the rural
Yeah.
areas here. Um,
Yeah.
so I've had patients get angry for me asking. I've had patients try to lecture me about how I don't know what I'm talking about. And then that's fine. I just take it all with a grain of salt. And I said, well,
Right.
let's just take care of you, do the best we can. Um, what's nice is even in the rural areas, it did take a little longer for us to get the vaccine. Because we don't have those deep freezers, that required the storage. So we in the rural areas, Pfizer was not even available at all because
Oh,
you
wow.
have to have those really super deep freezers initially.
Yeah.
So you'd find those mostly in the communities with universities or, larger urban centers. Um, so we had to wait for the rollout of Moderna. And then because we don't have a lot of the uh, big chain pharmacies that made deals with
Yeah.
the government to get access, it took even longer. So
Wow.
so there wasn't wide availability as quickly as it was in the urban centers. And so we really started with the elderly population, making sure everybody in the nursing homes were vaccinated. And by golly, even my uncle wouldn't get vaccinated because it's really hard. Like I really struggle because my family, I have a large faction of anti-COVID vaxxers, not anti-vaxxers, but just
Just
COVID
the
vaccines.
COVID.
Um, in my own family and even some of the elderly people in my family. So it's been difficult that way. But the experience as far as patients coming in and then trying to educate them about taking care of themselves and trying to prevent future issues is a lot more difficult. A lot of, you know, I've had people rip off their masks, and I say, well, you need to put your mask back on because, you have these respiratory symptoms. Well, I don't believe in all that. And I said, well, then you have the right to leave, but I really do need to have you wear this mask to protect everybody else around you. In small rural hospitals, we don't have a lot of ability to keep people away from other people.
Right.
Um, Especially when the pandemic first started, we had no negative pressure rooms. Half of our ERs just have curtains between beds.
Oh,
And our
wow.
trauma bays are all curtains between beds. And so that mask was a super important thing that we needed
Yeah.
to utilize. Luckily, as the pandemic went along and money started pouring in for pandemic relief for they could start doing makeshift negative pressure and putting in equipment for makeshift negative
Yeah.
pressure rooms. But um,
Um, since, I'm assuming, the rollout for the adult vaccine was met with some opposition, and there was just approval for the 5 to 11 children's vaccine, and that was very recent. Do you expect there to be a delay in that vaccine becoming available in your area, and what do you think the reception will be to that?
so I live this dichotomous life. So my immediate family moved to Iowa City in 2010 for my husband to get his graduate degree. Um, and I continued we continue to live here basically. And I don't think we'll ever leave because my husband is planted and my kids, this is the only school they've ever known because
Right.
they were very, very young when they came here. Um, and um, so in Iowa City, it is where the biggest university is in Iowa. So the University of Iowa, Big Ten.
Yeah.
It has the highest level of care here. We are the main trauma center. We have all of it is the main referral hospital for severe illness. Um, and so in our county and our city, most vaccinatedest city in the state of Iowa, most vaccinatedest county in the state of Iowa. Everything is readily available. In fact, when the 5 to 11-year-old vaccine became available, our school system, I mean, we are super blessed. Our school system is now this week holding vaccination clinics in 10 of our 13 elementary schools. They're actually
Wow.
vaccinating kids in the schools, right? So this
Wow.
is like, and my children, as soon as my children are both teenagers now, they weren't at the time of the vaccine. My son just turned 13, but they were both 12 and older. So as soon as that vaccine became available, they got the vaccine the next day.
Wow.
In the rural, it's a completely different experience. My
Yeah.
parents still live in that rural little county that I was talking to you about. It took them a long time to get their first vaccine, and they are, of course, elderly.
Yep.
And they haven't even gotten their booster yet because they can't find availability for the booster, and that became available before the 5 to 11-year-old, right? Which
Wow.
of course
Yeah.
scares me, because I'm
Yeah.
like, we need to find this, and so I'm contacting their providers. So yes, so I do not even think now that it's available yet for that age group. Do I think parents are going to give their kids that vaccine? Nope. I mean, I
Okay.
think that there are going to always be a collection.
Yeah.
But I think the most recent, it was something like, the NPR does the Iowa Public Radio, and they do some of these
Yeah.
little polls. And I think it was something like 28% of parents say they're going to vaccinate their children. Is for COVID, right? Now
Yeah.
this is not, yeah, it's a very bizarre experience because they aren't
Yeah.
anti-vaxxers. It's really
Yeah.
interesting. But I have yet to encounter a parent saying, yes, I'm absolutely giving my child the vaccine um, in the ER, like,
Okay.
or hospital setting that I've been working at, hospitals where I've been working.
Okay.
Um, they don't see it as a thing.
Okay. Well, kind of shifting views to more of a broader view, could you describe how COVID has impacted your current position overall?
Yeah, like I said, I've actually my work has load has increased.
Yeah.
Um, so, like I said, because of the staff shortages, when COVID first came to be, where we didn't really, nobody saw it in Iowa when all of these um, uh,
New York and
policies were being
Florida.
put in place.
Yeah.
And they're like, well, why are we doing this? Because I don't even see any COVID. Why are we
Yeah.
not seeing elective procedures? Why are we? And so um, I was asked a lot more to cover shifts.
Yeah.
We had people moving on, people being let go, people being uh, temporarily let go. Um, so and now and so and then for a while there it was like a ghost town. So they
Yeah.
needed somebody on to cover, so I would have more hours. But there wasn't a lot coming to the ER because people were trying to stay away because they didn't want to
Yeah.
get sick. They didn't want to. Um, and now the ERs are overwhelmed. Like, I am busy all of the time, and it is a lot more higher acuity. And I'm sure it's because people weren't seeking care earlier, so their medical problems have gotten a little bit worse, and they're
Yeah.
coming in and they're more sick than they have been. Um, and it's a mix now because we still have pockets of outbreaks with Delta, where in the small towns, in fact, just now I got another call from my cousin, and she said, oh, one of the first grade teachers, because they don't wear any masks in the school in my hometown, um,
Gotcha.
because COVID is not a thing.
Yeah.
One of the first grade teachers brought it to their entire class, and then so all of these first graders have COVID now. And so now everybody's worried, right? Because you bring it
Yeah.
home. So I just got a call, and I mean, come on, it's October 20, or it's November 2021 now, right? It's November
Yeah.
2021.
Yeah.
What in the world? You've had COVID's
Right.
been around, for almost a year. Actually, a year, yeah, yeah, almost 2 years. What the heck?
Right.
Gosh,
Yeah. Yeah.
So for me, I am actually overwhelmingly busy right now. And a big part of it, I'm in these little tiny small critical access hospitals that I don't have access to a lot. I don't even have same day lab for some of the things that I need all the time, like it's a send out for some just
Yeah.
basic things like magnesium levels. I'm sitting on these super sick people because I can't get them out for hours and hours. I will
Yeah.
call one example. One of the hospitals out in Western Iowa, which is sort of the most difficult hospital I work at because they don't even have staff buy-in.
Yeah.
It's a
Wow.
very bizarre, it's super, I'm not trying to be political at all, but it is very much, unfortunately, impacting care. Very politically conservative. And so even just nursing staff, uh, they only put a mask on when they go into a room with a patient. Otherwise, they're mingling around together, not masked. It's a very interesting. It's completely different. But there,
Yeah.
and there, we had to hospitalize, COVID patients, and a early 50s gentleman. This is his third COVID diagnosis, but this time he was really, really sick, and they had him on the highest level there. The highest level of oxygenation they had available is BiPAP. We couldn't intubate. You can't keep an intubated patient there. Um, they the nursing staff called every hospital in Iowa, Minnesota, Wisconsin. No hospitals taking critical patients. Had to get a biplane out of Wichita, Kansas, to come pick up the patient in Western Iowa, to take them to Rockford, Illinois, because that was the only place they could find a bed. I mean, it was ridiculous. They called 36 different hospitals and hospital
Wow.
systems. Um, and when I say 36, some of these transfer centers you call are transfer centers for like 10 different hospitals, right? So
Yeah.
many more than 36 hospitals. It was
Right.
closer to probably 100 hospitals. Um,
Right.
and that is the experience I'm still having right now. And it's not because we have a huge outbreak of COVID. I mean, COVID is still very active in Iowa because of Iowa politics, unfortunately.
Yeah.
But they don't have the staff to staff all the beds they need, right? Because
Yeah.
initially they'd let go of staff, and some staff have left because the COVID burnout.
Yeah.
And so, and COVID patients in the ICU stay a really, really long time. So they
Yeah.
don't give up a bed as easily. And so,
It
I,
doesn't take a lot of patience for it to remain full and stay full for a
yes.
long
And
time.
so then for
Yeah.
patients that aren't COVID related, I don't have a place to send them. I'm in this little
Right.
tiny critical access hospital, and I had a patient come in DKA. pH was 7.1, and Bicarb was only 8. And I'm in this hospital where I can't even get all the labs I need to follow closely. So I've got a patient on an insulin drip and fluids, and I had to manage the fluids, and I couldn't even get my electrolytes back to manage fluids, and you worry about potassium levels, and you worry all about. And I
Yeah.
sat on that patient in this hospital that I didn't even have full lab. And thank God, I mean, and we only have there's one ER nurse. I'm the only doctor for the entire hospital, one ER nurse, one floor nurse, and me. And
Yeah.
whereas it doesn't, 3 patients don't seem like a lot on the floor, but when you only have one nurse and 3 patients, I'm taking care of those. And then you have other patients coming into the ER, but I only have one nurse. And she
Yeah.
had to be one-on-one with this DKA patient. Diabetic
Yeah.
ketoacidosis is what I'm talking about. Um, and I can't tell you, I called Minnesota, Wisconsin, Iowa, no ICU beds anywhere. And I'm like, you know what? Can I just give me a medicine bed? I'm not even
Yeah.
I don't even have the medical facility. And really, honestly, this is only one of many that I've been through.
Yeah.
And in this case, I like my last I called the university back because they said we don't have a bed. Maybe we'll have a bed in 2 days for you. So I called the university back, and I'm like, you are my only hope here. I really, really need to talk. Can you please just put me through with a doctor, like an ICU doctor, even a hospital, somebody I can talk to, because this patient, if she's going to make it, she needs to be someplace where we can at least get labs back right away.
Yeah.
Um, And I had a MICU fellow, a medicine ICU fellow call back and was like, okay, we'll take her. I'll take
We'll
her.
make it
I'll
happen.
do this for
Yeah.
you. Um, so this is what I'm experiencing right now. And it is, I mean, super stressful. You don't have what is available and you've really got to make do. And this is happening everywhere and every single shift, I'm sitting on super critical patients. Like we have bad trauma patients I can't find beds for. I had a patient that had a heart attack for God's sake, and I'm calling all over the place. I'm like, they need to go.
Yeah.
And they're like, well, is it a STEMI? Is it a ST elevation MI? Is it, and I'm like, no, but this patient is super sick and I can't get like,
Yeah.
needs a
So
cab.
you're never working a shift that's an easy shift, is what you're saying.
Sorry.
It's
Yeah, I get
difficult
a little
every.
passionate about this stuff, but
No.
yeah, and then we're keeping patients that generally we wouldn't keep. So
Yeah.
in these small hospitals when we don't have all the capabilities, and you've probably seen the research, small like people, if you don't have immediate access to a stroke center, people don't do as well. If you don't have immediate
Yeah.
access to a cardiovascular center, people don't do as well. So you see people not having greater as good outcomes in rural areas because they can't get the care they need. And that's exactly what we're experiencing. Um,
Yeah.
and it is, while it's not because we have a huge rush of COVID, it is related to the COVID pandemic that this is happening.
Yeah. Yeah. Would you say though, given your background as a family doctor, do you feel like that makes you more uniquely prepared to be able to handle the pandemic than those who are more specialized?
Well, that's a great way to bring this all back, right?
Yeah.
I think that is absolutely true. And part of the reason I say that is because I even the uniqueness of my training, and actually just what we can do as family doctors. I think that is absolutely true because I have always had to work through multiple difficulties, multi-system issues, multi-age issues.
Yeah.
A lot of specialists saying, "Oh, go back to your primary care doctor for that," right?
Yeah.
And so I think it does make us more uniquely qualified to do this, and I think that's why family doctors stay in these areas, right?
Yeah.
That's why you don't find ER trained ER doctors in rural areas. You don't
Yeah.
find internal medicine trained doctors in rural areas. As much, the
Yeah.
family doctors really, that is their bread and butter. And so and uniquely myself, I actually trained in the inner city, and I have worked urban inner city, and 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 rural in addition, and where there are always lack of resources, and so you learn how to be able to work with little.
Yeah.
And I think that uniquely puts family medicine at the forefront of this kind of work. Critical access hospital work, uh, rural health center work, ER, small ER work. I would
Yeah.
never work in an urban ER. I don't have that kind of training. I don't have the
Yeah.
training for multi-gunshot wounds. And I fully, I fully admit that. I
You
would
know
never,
where your limit is with regard
yeah,
to that.
right.
Yeah. Yeah.
But I think that we have to manage so many multiple things just on a day to
Yeah.
day as a family doctor, whether it be in the clinic or whether it be in the hospital or whether it be in the ER. And some family doctors like myself earlier on, I did broad spectrum, cradle to grave. I did deliveries, I did hospital, I had nursing home, I had clinic, and
Yeah.
I'm educated. I was an attending physician, so I worked with students, and we know how to manage all that stuff. The
Yeah.
paperwork, on the other hand, is something completely different. But as far as like the clinical issues at hand, we're uniquely trained to do that. Um,
Absolutely.
I think
Absolutely.
other people might sort of run away being like, but
Yeah.
we
Yeah.
tend to I don't know what it is. We tend to run toward the dumpster fires, we tend to
Yeah.
run toward it and say, what can we do to help? Um,
Right.
I don't know. I think it might be a little bit of a mental illness that all of us family doctors have, but kind of goes along that way.
Yeah. So thinking towards the future, where do you see family medicine going?
Wow.
Big question, big picture question,
Yes.
right?
So, this kind of gets to, I feel a little bit sad about this because I feel like, I was an attending in a residency and that residency closed. And one of the oldest residencies in Iowa closed.
Wow.
The so the University of Iowa and the Cedar Rapids Medical Education Foundation, they argue with each other about which one's oldest for the family medicine residency. They opened around the same time, so in the early 1970s. Um, and that residency closed because the hospitals didn't want to support it anymore. There's two hospitals. Um, and it was very sad for me. But what I was seeing in the residents as they were graduating is they were all specializing. They were
Yeah,
all like, great things. I mean, there's a lot of things you can do in family medicine, which is amazing.
yeah,
Like a lot the residents were going on to geriatric fellowships. They were going on to sports medicine fellowships, like great
yeah,
things. Hospice and palliative care. Um, Actually, some operative OB, and those residents came back to small town. But they were all leaving. I shouldn't say
yeah,
all, a chunk were leaving. And a lot of
yeah,
them are going on to do hospital medicine. Like we had a lot of graduating from our residency doing hospitalist stuff. And it's because of um, the lifestyle.
yeah,
And so as a small, like as a broad spectrum family physician, which is what I always wanted to do, was my like passion. And it's hard. It's
yeah,
really hard, especially if you want to have a family, you want to be able to be at your
yeah.
family events.
That balance. Yeah,
Not to bring in gender, but there's a lot of women graduating family medicine, and if you want to have a family and
yeah,
you want to do broad spectrum, it's really hard. It's really hard. And more and more and more demands are being put on the primary care doctor, things that are completely sort of insurance driven and kind of ridiculous.
yeah,
And so you never get to leave. You never get to leave your
right.
practice. You might go home at the end of the day, but you've got
But your mind's still
this.
there. Yeah,
Well, you've got this in your inbox.
yeah,
And so you are taking care of that patient 24/7, even though you aren't
yeah,
seeing them in clinic. Um,
right.
and you're doing a lot more. There's checking the boxes for the quality stuff and all those crazy
Oh,
things
yeah,
that take a lot of your time and take time away. So unless things change like that, I feel like the broad spectrum family doctor is going away. It's going away. I
wow.
graduated from medical school planning to do cradle to grave medicine, which is what I did for several years. And it took a toll on my family. Like I had a baby and I was back to work. I was back to work within 6 weeks of my first baby.
Wow.
And my husband would bring her in to breastfeed in the middle of the day at my lunch hour. I mean, it was, it was really, really hard.
Yeah,
I, and then when I had my second son, I was like, screw this, I'm taking 3 months.
yeah,
Or when I had my son, because it was, yeah, I mean, and so, um, I see the family medicine training is invaluable. But I see fewer and fewer doing OB because of the hours and the encroachment of a lot of obstetricians don't want to see family doctors doing OB anymore. Um,
yeah,
Similarly to some of the procedures, I had done colposcopies my entire career in medicine until one of the hospital where I was working decided that that was going to be a GYN only procecedure. I mean, I'm like, but wait a minute, like,
I can do this. I have the skills.
so it's so I unless things change where primary care is being considered a very integral part
Yeah,
of medicine and all of these extra outside pressures um, allay a bit. Um, I don't know that you're going to have the broad spectrum doctor around very much longer. It's
yeah,
it is, and I don't blame the young people. I say young people coming out who are like, wait, what is all this craziness? I thought I just want to take care of patients. I just want to
Yeah.
be there for the delivery of those babies and take care of those families and be there for the grandparents. And I just want to,
Yeah.
but what is all this other stuff? Like why,
Right.
and how come I can't train to do colonoscopies? Why I thought that was something I could do.
Yeah.
And so I think like in Alaska in some super rural areas, you can still
Yeah.
find it, but
Yeah.
it's a lot harder to get that training, and then so people are choosing lifestyle. So I
Sure. That makes
unfortunately
sense.
I've become more and more pessimistic about family medicine as the true cradle to grave.
Yeah.
Can we keep a hold of that? That would be great.
Yeah.
Um, and the thing I miss the most about doing the kind of medicine I do right now is I don't have that whole family connection. I
Mm.
miss that. I really
Yeah.
do. And being in the community where they see you at the grocery store. Oh, hey doc, can you look at my thing down here on my ankle or whatever? And
Right.
had
Right.
my pastor say, hey, I have this thing on my thigh. Can you take a look at it? Um,
Right.
but I miss that. But what I don't miss is missing all of my kids' stuff,
Yeah.
um, like missing important events in family life. So
Yeah.
I can make my own hours now. So, and I still
Yeah.
get to see broad spectrum problems because the ERs in rural areas, it's like clinic. A lot of it's
Yeah.
like clinic, you know. You've got
Yeah.
like heart attack in one room, and the next room I've got this rash
Yeah.
on my leg. Can you please look at it? Um,
Right.
so, but I don't have that continuity, and I miss deliveries a lot. Like my last delivery was January 2018.
Oh,
So I miss that too because that's a really important part in somebody's life. But um,
sure.
all the little small hospitals, they aren't doing deliveries anymore. They can't,
Yeah.
they can't afford to keep the liability up and whatnot. So um, and this is just my little area of the world.
Sure.
Other people might be having completely different experiences, but I see it contracting more than I see it expanding. And that
That
to
makes
me is
sense.
sad because
Yeah.
that's what I went to family medicine for is cradle to grave
Right.
medicine. And I don't know that everybody is doing that anymore when they're going into family medicine. They have more of a vision of something little less than
More
that.
specialized. Yeah.
Yeah.
Yeah. Well, I appreciate your perspective on that. Going back to COVID-19, is there anything that we haven't covered in this interview that you want to get in this interview related to COVID-19 and family medicine? Anything we haven't covered you'd like
Well,
to add?
I did one thing. I mean, and I know we've been hearing about this, and I think it's absolutely true. Um, that patient relationship that you have is what I believe impacts the most on decision making about COVID-19. And family doctors are in a unique position to do that. And I know I'm preaching to the choir, and I know that this has been shown over and over and over again. But just as an example, like I said, I have not during COVID-19, um, I have not been in clinic. So I have not had my own primary panel. But I have worked in my hometown hospital frequently. And like I said, I see my teachers there, I see friends of my parents, and unfortunately, I even see classmates. Um, and I had a classmate who has very severe asthma and a lot of other medical problems, unfortunately, who came into the ER. I had to admit him for a severe asthma exacerbation, and we were able to keep him at our little hospital. Um, and he was anti-vaccine, which was to me still super crazy. But and he's very high risk with other medical problems as well. And so one thing that's nice about having those relationships. Um, I graduated from high school with him, so I've known him forever. Um, is that, and also another nice thing about working in a rural area and having the broad spectrum is being able to spend some more time with your patients. So I actually
Yeah.
sat with him um, several times um, in the room because I had to round on him every day, and we
Yeah.
chatted about it. And I was I'm not going to claim all of it, but he got the vaccine, right? So we talked about it and talked about it and talked about it and talked about it and hashed it over and hashed it over. And you know, he has a daughter who's in high school, and we talked about the impact, what happens if, because unfortunately, his wife died. So of endometrial cancer a couple of years earlier. And so he was all she had. Like they had one daughter together. So he ended up getting the vaccine. And that's because of that personal relationship, right? And that is what family doctors can do.
Yeah.
So I feel like that just needs to be emphasized, right? Because you know, you have that brief interaction with your specialist, and they might be the best specialist on the face of the earth, and they did some great things. But with that specialist, half the time you can't even remember the name of that specialist, right? Or even remember exactly the last time you met them or visited with them. But by golly, your family doctor is not that person. That is the person that you are constantly in contact with, and you can have these heart-to-heart discussions, and you can hopefully impact their life in the broader way to make some healthy decisions for their bodies.
Yeah. Well, Jody, I'd like to thank you so much for doing this interview and being a part of history during this unusual time of COVID-19. And thank you for sharing your experience so far with this.
Thank you for having me. I appreciate it.